We have to move on to the symposium by Philips, dedicated on imaging by IVUS.
Okay, good afternoon, everyone. We're going to get started with our afternoon symposium sponsored by Philips. I'm Eric Sisemski. I'm the cardiologist who will be moderating this session with my escorts, which are two vascular surgeons. But we have a wonderful talk for you describing kind of where IVUS has gone in our contemporary practices. In the US, we've had reimbursement for some time, so this has become a really integral part of our practice. Again, as a cardiologist, we use this a lot interventionally in the coronary world, but our practices, and my practice is primarily vascular, has really made its way into the vascular space. But I have two experts here that are going to walk through their approaches, and we're going to have some time for some conversation. First, I'd like to introduce Dr. Ash Patel, vascular surgeon from London, and then we'll have Dr. Mark Porteau come up here. If you want to join us on the stage, Mark, also a vascular surgeon from London, and Ash is going to get us kicked off. So thanks, Ash.
Thank you very much, Eric and Philips, for the kind invitation to speak today, and for the PVI organisers. I think we have a bit of a treatment paradox here. You've heard today there are a range of devices for treating CLTI. There's atherectomy, laser, DCBs, etc. We have tools for crossing these lesions. But the thing is, IVUS is a diagnostic tool. It's not a tool to treat lesions. And it helps us understand the biology that we're treating. And it also helps us to understand the mechanisms of failure. You saw today with a few occluded stents. IVUS might decipher why these stents have occluded. Now, I'm not going to talk to you about the large data sets available or try to convince you that we should be using IVUS, because it's about how to use IVUS. But we all know there are some really big data sets from the States, and there's an RCT showing the benefits of using IVUS in FEMPOP interventions. When you put all that data together, and particularly in patients with CLTI, what we know is that IVUS really reduces your rates of amputation, mortality and readmission, but the main point is that it reduces your reintervention rates. And the meta-analysis, you put it all together, it shows that IVUS, there's now a shift in the pendulum towards increased patency, improved TLR rates, and a reduction in major amputation if we use IVUS. However, I think we have to be really careful here. It's about how we use IVUS. And in really large population cohorts, I think if we use IVUS incorrectly, actually you might not tease out the real benefits of using such technology. And possibly that's why we're seeing experts in the room not actually using this device. So here's an example. Here's a very short FEMPOP lesion, a short stenosis. How would you use IVUS in this case? You pass the IVUS down, you see a lesion. At which points in your workflow are you using it? Are you measuring the lesion beforehand? Are you measuring your outflow? Are you planning your healthy to healthy segments? And after you treat your lesion with atherectomy or laser or even just POBA and DCB, how do you then decide that my procedure is completed? Does IVUS actually add value here? And when is IVUS most effective? So we've seen DCB data recently where actually perhaps we're not teasing out the benefits of these great technologies. And perhaps with IVUS, if we're measuring these lesions appropriately and sizing properly, you might tease out the real benefits of DCBs. Where we're finding it the most effective is below the knee. There's some real changes in the pendulum here, where you get real impact in terms of lesion morphology and increasing your lumen gain as a result of using appropriately sized balloons. We talked about a consensus. Is there a consensus on using IVUS? Well, this sort of half-decent paper here, Eric, kind of showed that maybe there is a trend towards a consensus. I think we know that IVUS is really useful in the FEMPOP segment, and we're seeing it really useful in the tibial segment. In the iliacs, we're not quite sure. And Eric didn't just stop here. They carried on to then really go into when should you use IVUS. Is it in the pre-intervention to assess the lesion? Is it during your procedure? To determine where your wire is, sizing a vessel, and then after your treatment, how do you then decide what to do next? So in our really early practice a few years ago, we started using IVUS we weren't quite sure when to use IVUS, before treatment, during treatment, and we're using it sort of just based on the lesion complexity and more complex cases. What we did find, though, we were noticing cases where there were dissections that you didn't see on angiography, We ended up bailout stenting them, and we noticed stenoses, which ended up us treating these lesions further. And we were starting to tease out the real value in IVUS, and we came up with a workflow, and the workflow says, pass your wire down, assess the lesion, treat the lesion, and then check that you've done that properly with the IVUS, and when you're really happy with your outcome, then you do a final angiogram. So this basically mitigates against using contrast and really reduces your radiation exposure. So this is Aslan Wafi, he's one of our fellows. So we thought, let's look at the literature and work out where are the gaps in IVUS in terms of how to use the device. So we went through a few thousand articles and assessed these cases, and all these articles were situations where IVUS had been used in the FEM-POP segment. So here are the main questions that arise out of IVUS use. Number one, how do you acquire the images? Is it automated pullbacks? Which catheters do you use? Do you use chromaflow? Do you use virtual histology? Number two, what is IVUS used to assess? Do we assess the lesion morphology? Do we use it to assess calcium? Are the lesions tortuous? Is that relevant? These are all the questions that came out in our lit review. And essentially, all these are the questions that we need to answer as a group, in order to have a consensus on how to use IVUS. And once you've prepared the vessel, how do we then interpret this? Do we use lumen gain? Do we use area? Do we use stenosis? I think this is really important that as a group, we come to an agreement in this is how best to use IVUS in our cases. And after stenting, do we use it to look at stent apposition? Is it any value? Is there any value in looking at stent eccentricity, compression, the edges? Where are the benefits? Otherwise, it gets too complex and too nuanced. So we ran a little questionnaire in an IVUS course that we ran internationally. Quite a few experts who do FEM-POP interventions, and here are the areas that we're going to focus on: is how to acquire the images, how to interpret these images, and finally, how does IVUS help your decision making? And that's our current consensus, and we're currently in round two, and we should have those data in readiness for link. And I'll just end with some cases. So here's a straightforward FEM-POP case, SFA stenosis, really small vessels. So how do you use IVUS here? So I've used it to size the vessel, to assess the morphology. Is this lesion useful for atherectomy? Is it an IVL case? Is it a Rotarex case? And here's where IVUS is really useful in our case, but we still don't quite have a workflow or a consensus in understanding which points are we using IVUS appropriately. So here I use atherectomy. Here's a Phoenix atherectomy device, and then a POBA and a DCB based on the appropriate sizing on the IVUS. And this patient had a decent outcome. You can see a small dissection in the distal SFA. Again, you might use IVUS to assess that, to understand, is it worth stenting, or should we leave that alone with DCB? But here's a very similar case, a longer SFA occlusion, a CTO with quite a hostile cap. The wire flies down. It's the straightforward case for atherectomy or Rotarex, and here you use the IVUS. And what you might notice here is actually on the pullback, the wire's in the lumen, but all of a sudden we weren't expecting this, but actually the wire is actually subintimal halfway through the SFA, and that totally changes your thinking. Here's a wire entering subintimal just here. And it changes your thinking. No longer can you use atherectomy. You can't use laser. Your only option here is POBA and then bailout stenting. But again, you can still use IVUS to size and place your markers for your healthy proximal and distal. And again, after stenting, you can use IVUS to really assess that lesion and make sure that you haven't got any disease proximal or distal to your stent. Your stent's wide open and there's no compression. And that's where we're using IVUS at the moment, but we don't have a consensus on its real benefits. So to conclude, I think we know that IVUS is useful in PAD, especially in CLTI in the more complex cases. But the patterns vary so much between sensors, as you've heard today, and operators. And we haven't got a standard of how to acquire the images and how to interpret them. So hopefully our Delphi consensus will address that gap, and you'll hear more in a few weeks' time. Thank you very much.
Great, thank you, Ash. Before we move to the next talk, quick question for the audience. Who's using IVUS right now in their lower extremity cases? Anybody in the audience? Great, we got two in the front row, both cardiologists? Radiologists. Okay, radiologists, cardiologists. Anybody else? Anybody feel, we got one more hand here. Anybody feel uncomfortable interpreting IVUS? So Ash showed a really nice case. I don't know if you noticed the wire was in the subintimal space. It came back into the lumen. Is everybody able to see that? So Ash, a couple questions for you. In your practice, how many cases did it take, would you say, before you got comfortable being able to stand up here and teach IVUS? I mean, was this a 20-plus case experience, or was this a couple cases?
So there's two things here. One is your setup. So it always feels like it's going to take a bit longer, you're wasting time, it's fiddly, it's no one-for-all system. Actually, if you get your setup right and you know your workflow, it takes, I would say, 3 to 5 cases to really understand what you're looking at. It doesn't take many cases. We have fellows in our institution who do a few cases, and they're so adept now at using IVUS. Obviously, the nuances, it takes a bit longer, but just to understand the image and see what you're seeing, a handful of cases, I'd say.
And I get a question a lot of, do I need to use IVUS in every case now that I started using IVUS? Now it's a mandatory, or how do you kind of pick and choose and think about it?
So that's a tough case, a tough question. So there were a few comments today in the session about we haven't got the funding, it's expensive. Look, if you're going to be using atherectomy or laser and DCBs and stents, that case is for us a £5,000, £6,000, £7,000 case. And for us, IVUS is about 10% of the overall case cost generally in the UK. So at the moment, for FemPop and especially tibials, I say we're using IVUS in more than 2/3 of cases. But I think the ethos is to get your procedure right the first time round, so the patient doesn't come back for that really costly TLR.
Yeah, I love that comment. I mean, I think what you start using IVUS, you get a little addicted to it, because you get to these points in your practice where you're used to making decisions and you're kind of guessing, and all of a sudden you realize you don't have to guess, right? You're like, why don't I just push IVUS down real quick, make sure I made the right decision here, and then move to my next step. And you showed one randomized trial and then another randomized trial. There's 2 randomized trials now, and the theme from both of them is just IVUS. Remember, it's an adjunctive tool. It's not a therapeutic tool. It's an adjunctive tool. Improve patency by between 15 and 17% at 1 year for FemPop intervention. So just using, I always call it like DCB on steroids, right? Like if you have a DCB and it works well, but you use it with IVUS, you're getting an extra 10 to 15% benefit for the patient, as well as CDTLR, just by using an adjunctive imaging device. And a lot of that is sizing and healthy to healthy reference vessel. Please.
Just one question and having your feedback. We know that companies are looking more and more about new devices to optimize the treatment of endovascular therapies. Don't you think that IVUS can optimize the use of current devices available, and that we can improve, and we saw it in different studies. So perhaps we already got all what we need, but the way we use them can be improved by using the IVUS, and then we improve our final result.
I think you're spot on. If I had a company and I had a device that I thought was really useful, I would mandate a study with IVUS use to make sure that you tease out the real benefits of that device. IVUS isn't a tool to do something, it's a tool to improve the outcomes of your devices. Totally agree with you.
Yeah, in the US also, we have really an overuse for some device issue. And so we use IVUS also to demonstrate the device is needed. Don't use atherectomy in every lesion if calcium is hard to determine. Prove you have calcium that requires it. Choose an IVL balloon if you see medial calcification. Make sure you're not subintimal. So I think that it also helps us be better decision makers for our device selection, and that can be cost saving as well. So we're going to move now to Mark, and Mark has a great talk for us. And if you had a comment also, please.
Yeah, I was just going to say, Eric, to your point there, just think about a DCB and think about how frequently the understanding the actual true reference vessel diameter off angiography. Using an undersized DCB, you're washing the drug off and you're not delivering it to the wall. So something as simple as just getting it accurately measured will no doubt improve the utility of that alone without vessel prep, for sure. Okay. Let's wait for my talk to come up. I did put it on late, so sorry.
We'll pull up the next slides. Oh, okay, they're coming through.
It's coming.
Okay.
Here we go. So good afternoon, everybody, and thank you very much for that lovely introduction, Eric. I am a vascular surgeon from London. My name's Mark Portu, and I stand before you as somebody who is committed to trying to improve our outcomes with endovascular interventions so that we can look my vascular surgical colleagues in the eye and show them that there is a genuine parity in terms of long-term outcome. And I think IVUS is essential to doing that, because one of the issues, as you see repeatedly, is about the need for reintervention in endovascular procedures, what we're looking at here is something that helps us make better decisions, and in every way that my colleagues have described, have demonstrated that it helps you make those better decisions. So look, I'm not going to dwell too much on this. You guys are all familiar with what vessel preparation is. I would put it to you that it is any step that is performed prior to your definitive treatment. And your definitive treatment, you're well aware, would be your drug-coated balloon or stent, drug-eluting stent. It could be a non-drug-eluting stent, or it could, in certain situations, certainly where there is no clear evidence to the contrary, a plain balloon. So how do we do it? Well, again, we've heard a lot this morning about the aspiration of thrombus and the rotational techniques of debulking the lesion, but there is also that plaque modification category as well, which is very much where IVL and specialist balloons come in, and then sometimes high-pressure angioplasty. But why do we do it? We do it because we want to cause less damage, we want our interventions to have a better procedural success, and we want them to last longer. That's why. This is something that I was a willing participant in. It was a consensus. It's not the same as the one that Eric chaired, but this is one that's pending publication. And it was very much aimed at the process of vessel preparation. And the questioning was very much about how does one decide what technique to use. And very clear, it relates to the morphology of the plaque we're dealing with. So how do we assess our plaque morphology? Well, there are a number of discussions, I remember at the time, but there was clear consensus that IVUS and probably the haptic feedback as to how the wire actually traverses the stenosis or occlusion are the two most reliable ways of determining what your plaque morphology is. So everything else we can talk through. So this is an external ultrasound. This is an IVUS, and the eagle-eyed amongst you will see an acoustic shadow cast from a horribly calcified plaque. Fairly uncontroversial. You'll see the same patient with rocks of calcium in both the common femoral and in the SFA. Slightly less resolution here on how severe that stenosis might be, but certainly the presence of severe calcium evident on your CT. So what about fluoroscopy? Again, same patient. You very clearly see exactly the same areas that correspond to those two modalities. And this was the IVUS of that particular level. You see that when you're actually looking at the image, it doesn't project hugely well because of the lighting, but what you'll see is there's very little information outside of that medial calcification and the intimal calcification in the first picture. So calcium's easy, isn't it? But tell me something, I almost want to go around and ask you all, which one of these shows the soft plaque and which one shows the thrombus? Any guesses? Which one's soft plaque, which one thrombus? What about the angiogram? That's the angiogram of the popliteal CT I just showed you. Any guesses? I mean, if I told you that the history was of a sort of vague history of short distance claudication, does that help? Not really. Well, I can tell you my colleague did this angiogram. He made a decision on the basis of the history and the way the wire passed that this was soft plaque. So proceeded to perform preparation with a plain balloon angioplasty, thinking it was soft plaque. And what happened? Trashed the one vessel runoff that he had because the diagnosis, the plaque morphology assessment was wrong. And what we saw there was trashing into the one outflow, an absolute disaster. I get a call, we were able to save the day by using a Rotarex. This is the 6 French actually, although I mostly use the 8 French person when I do Rotarex. But you can see here that getting that decision wrong nearly had catastrophic consequences. So how would the IVUS have helped us? Well, this is a little cartoon that I made where you can see that the actual image on the IVUS itself gives you a very, very, very clear differentiation between the different plaque morphologies. It isn't just calcium that you can see. What you can see are the way that the stenotic or occlusive disease forms within the lumen. You can see the density or the echogenicity of the of the stenosis or occlusion, and it gives you a very clear idea about whether you're dealing with thrombus, you're dealing with thrombus of a slightly longer age, whether you're dealing with mixed plaque, which you very often are in the occlusive cases, or whether you're dealing with soft plaque only. And then your decision as to what prep modality you choose can therefore be informed accurately. So this is another consideration that was mentioned by Ash as well, and that is, where is your wire? You cannot be sure when performing a CTO crossing that you have remained luminal the entire way, however well you think the wire has traveled. And the truth is, you will be surprised when you do enough IVUS. You'll realize that there are times you step in and out very frequently. Let's go back for a second. And this is exactly where this comes in. You can see where is luminal, and you can see clearly where you are subintimal. Why is that important? Well, it's important because a number of the rotational-based devices, the Rotarex and the Phoenix rotational atherectomy device, require you to be luminal. They require you to be actually engaging the plaque. If you're in the subintimal space here, then the very worst that's going to happen is it's ineffective. Sorry, the very best that's going to happen is ineffective. The very worst is that you're going to cause damage to the vessel, probably perforation. Shockwave is one of those. It was no doubt that it can be affected in the subintimal space, and it's certainly not off IFU, but there's also no doubt that you're wasting half the energy out into the soft tissue. So luminal position is important to understand when selecting your vessel prep devices. We've also mentioned, Ash spoke beautifully on accurate measurement of reference vessel diameter. This is how I do it to the external elastic lamina. It's the way that I believe the true experts do. And I'm going to show you a case now. So this is a duplex scan that shows a very tight popliteal stenosis and a anterior tibial disease that's hinting that there is a problem here with calcification. So there's the static angiograms. How big is that popliteal?
5 millimeters.
5 millimeters, okay. 5 millimeters popliteal. Okay, what about the anterior tibial? Every time I move my hand, it moves it to slide forward. How about the anterior tibial? How big's that? 3. Okay, well, let's have a look. Let's see if you're right. So you are right when it comes to the popliteal. Okay? But bearing in mind that the majority of the data that I've seen would underestimate the reference vessel diameter on angiography by about 1 millimeter, sometimes it doesn't. And actually, sometimes you would be correct. But it's important to know that. But what about the anterior tibial? At the level that I'm showing you. This is the co-localized, this is the co-registered position of the IVUS. Actually nearly 4 millimeters. A lot bigger than you think, isn't it? So if I've selected my vessel prep device here, and I actually chose a Shockwave M5+, this was before E8 came out, what size am I picking to treat both? In this situation, I chose the 6 millimeter M5+. So I'm using a 6 millimeter IVL in the 4 millimeter vessel. And then I would say with an aggressive oversize there, I'm likely to be able to get a very good result by using a very low inflation pressure. So in this case, it was only 1 to 2 atmospheres in the anterior tibial, and then the normal 4 to 6 atmospheres in the popliteal. Post-dilation with a plain balloon wasn't necessary, because I was able to check on the IVUS. And what I'm concerned about in this situation is causing the very kind of problems that you are trying to prevent by using IVL vessel prep, like dissection, like embolization. So the IVUS was possible for me to be able to check the success. Oh, hang on, that's just really jumped forward. Hang on, guys. Yeah, so here I selected my DCB on the basis of the true reference vessel diameter as measured by the IVUS, and I think the result was very good. There was a pulse in the dorsalis pedis at the end of the vessel. Post-procedure evaluation, it's not enough just to do it or to select what we think is the best device and to deploy it optimally. We also need to check if it's worked, because it is very much these lesions left behind where you think, it's probably not flow limiting, what have you. These are the ones that are causing your TLR procedures or failure of your intervention down the line. And in this situation, this was a selection for a plain balloon prep with a DCB treatment because of soft plaque. This is just jumping forward. Wow. But what you can see is a number of dissections which I was able to evaluate with the IVUS, having a much better idea of what was severe and what was likely to cause significant problems. So in doing so, I can co-register exactly where these issues are, accurately on the IVUS. I generally save where the catheter is, and then come back and then selectively treat. And in this case, it was just a prolonged, shorter balloon. And in doing so, we were able to achieve a satisfactory result, both on the angiography and on the IVUS. So actually avoiding the need for spot stenting or anything more drastic. And this is another really interesting point when thinking about how we think about these costs associated. If you're thinking about it in terms of, can I save a stent? Well, it starts to look a little bit more cost effective. If you can think about it in terms of, can I save another procedure at 12 months? Significantly more cost effective and less risky, of course. So when I did exactly the same as Ash and looked at what the cost related to our procedures by using IVUS, it's less than 10% when using vessel prep technologies and DCB, particularly if you're using more than one. And that, I think, is a price worth paying myself. So there are situations, of course, where people cannot have contrast. This is somebody that had an anaphylactic reaction to contrast. So in this situation, it was a very difficult CO2 angio. But by using the ruler to co-localize where the IVUS catheter was, I was able to map the length of the lesion quite accurately, establish the reference vessel diameter, chose in this case an M5 plus shockwave IVL, and then post-dilate appropriately with a DCB without using any contrast. So I think we've got about 1 or 2 minutes left. What I think I'm going to do is just quickly back through these. This is a situation of a below-the-knee disease, just exactly to Ash's point. I think my personal feeling is this is exactly where I want to be using IVUS. I want to make good decisions on vessel prep selection, on RVD, on luminal position, and all the things I've described to you beforehand. And in this situation, what we saw, this was down the perineal artery, was medial calcification and a number of areas of nodular calcification. So that was a selection, therefore, for an E8 shockwave. This was deployed in the areas we saw predetermined on the IVUS, and then I was able to reuse that same IVL down the posterior tibial, re-establishing pulsatile flow, which I'll show you now, pulsatile flow at the level of the ankle. So that's my post-procedure evaluation. No need to post-dilate. This was again, just very quickly, 30-second case of a long SFA CTO, and this is somebody that had claudication and then presented with a sudden deterioration into Rutherford 4 rest pain. So the history very suggestive of there being a thrombotic component. The IVUS confirms that, but importantly confirms that I am in a luminal position. So here I can go ahead and select what it is that I think you all know I'm going to say, and that is an 8 French rotor XS catheter. Again, sized appropriately. Sized appropriately because my RVD was around 6 to 7 millimeters. The post-treatment IVUS definitely showed areas that I was not happy with, and I'll just show you the highlights of that now. Areas of focal residual stenosis, and this was almost certainly the underlying lesion that led to that thrombotic occlusion. And in that situation, we were able to focus our attention, go back post-dilate again, but had that not gained the sufficient lumen or had recoiled further, I was in a position to more accurately size and place an appropriate stent. Came off the table with 2 vessel palpable pulses. And I'm going to stop there. Thank you very much.
Great talk, Mark. We have 2 more minutes. Any questions in the audience for us? So great. Oh, wonderful. Please. Come to you.
Thank you, Eric. A question for the expert. I still have a problem with calcified lesion. We can identify calcification in IVUS, okay? But what is your main criteria, not for calcified, but for resistant lesion? What are your main, except the ring, what was the criteria to define the lesion that will be not open with the balloon?
Either you want to take that, recalcitrant lesion that's not necessarily calcified.
So I'll take that. I think for us, if we see calcium on the IVUS and it's circumferential or even eccentric, my go-to is generally IVL. I'm not kind of worried that it's not going to be calcitrant and it should respond to vessel perforation. What I do though is at the end of the procedure, I'll wait my 15 minutes and I'll check with the IVUS to make sure that hasn't recoiled. So it's quite useful there. And actually, if you notice with Mark's slides, there weren't many angiograms. You had most of your procedure was done on IVUS, and you have a final angiogram at the end. I don't use IVUS I use IVUS for looking at my lesion and making sure it's treated correctly, and at the end is flow is the angiogram at the end. It's not used for flow.
Yeah, and a lot of times, fibrocalcific lesions are the ones that tend to recoil, especially without vessel prep. So those come across, calcium is white, but you'll see fibrocalcific disease show up kind of as a more gray with white speckles. And that's one where, again, a specialty balloon, a cutting balloon, an IVL balloon can be really successful and looking for recoil. So, there are different morphologies that can give you similar problems, just like a really recalcitrant, severe calcific disease. So, great question.
Just following on, from what Ash said, in the situations that you described, IVUS gives you the security of being able to go back and check it. So you can perform whatever prep technique that you see fit, but if you then go back and check and see that you have not gained adequate lumen, or there has been an issue, particularly with high pressure angioplasty, cause a dissection or otherwise, you are now informed, and now you know how to repair that. So I would say that it kind of almost takes away the need to have a guess as to how a vessel would respond.
Wonderful. So I know we're at time. I want to thank our wonderful speakers. Fantastic presentations. Thank you to Philips for sponsoring this symposium. Thank you to the coast directors of PVI. Thank you, everyone.
Thanks, Eric. Thank you.